I'd like to say good evening to everybody and welcome. And for those of you that don't know me, my name is Deborah Montague, and I have the honour of being the chair of ALK Positive UK. On behalf of the Board of Trustees, I would like to offer the warmest welcome to all of you to this conference. This is the largest gathering of ALK patients plus guests in the world outside of the USA. Could have had a woo. There we are. I would also like to welcome Professor Sanjay Popat, our Honorary Clinical Advisor. More from him in a minute. So, some of you are old friends, veterans of this conference, indeed, and I'm thrilled to see you again, and I can see you around. So, many are here for the first time, and perhaps you were diagnosed only a few weeks or months ago, and you may have walked in here tonight feeling quite anxious, uncertain, or even overwhelmed, and that is completely understandable. Please know that every single person in this room has at some point felt exactly the same way. That is why this weekend is so very special. You are no longer alone with your diagnosis. You are surrounded by people who, without even knowing your name, already understand a part of your story in a way that others simply cannot. You are among friends. This conference is our annual anchor. It's a place to learn from the leading specialists who have freely given up their time to be with us. But it is also so much more than that. It is a place for the equally important human side of this journey. It's for the conversations over coffee, the exchange of experiences, the simple, powerful act of saying, yes, I know exactly what you mean. Tomorrow and Sunday will be packed with information, but tonight is about connection. Tonight is about breathing out. It's about sharing a meal and realising that the person sitting next to you gets it. When I was first diagnosed 9 years ago, I desperately searched for someone, anyone, who was living with this disease. It felt like I was the only one. Setting up ALK Positive UK was my lifeline. It became my family. You are my family. And my greatest hope that this weekend you will feel like that too. So my message to you is simple. Ask questions. Our medical experts are here for you this weekend. Share stories. Your experiences are invaluable to others. Make connections. Exchange numbers. Find your people. And most of all, hold on to hope. The science is moving at a breathtaking pace, and we are at the very forefront of that change. We are not just patients, we are a powerful community driving progress. Now I can't change the page. I was doing so well. Thank you for being here. Thank you for your courage. Thank you for being a part of this ALK Positive family. Now, please, enjoy the rest of the evening, and you'll talk, laugh, and connect. And I look forward to speaking to many of you over the weekend. However, now I would like to introduce our keynote speaker, Professor Sanjay Popat. He is a consultant medical oncologist at the Royal Marsden Hospital. He is a renowned international global lung cancer expert. He is also the charity's Honorary Clinical Advisor, and he has been a great support since the charity has formed. Professor Popat.
Well, good evening, everyone. It's, as ever, it's a great, wonderful honour and pleasure to be standing before you at this dinner to talk to you about various aspects of ALK Positive lung cancer. Now, I'm a jobbing clinician. I see patients, and I was doing my ward round late on Wednesday, and I popped in to see one of my inpatients, She's somebody I've got in at the moment who's got ALK positive lung cancer, and she was telling me how disappointed that she's going to be not to be here. That was the first great tip, because I thought, oh yeah, I thought I was going to be doing something on Friday, so thanks for reminding me on that one. And then we got chatting, and we were sort of just chatting about various things, and she said to me a phrase that really stuck, which was, I've had several great years of quality of life. And that's really important. So I want you to remember that phrase for a minute, and we'll just reflect a little bit about how we've got to the place where we are, where the vast majority of you in this room are taking a simple, straightforward tablet to switch off the cancer. ALK positive lung cancer hasn't always been known about. It's a relatively new finding. When I started treating lung cancer as an oncologist back in 1997, there wasn't anything like different subtypes of lung cancer. It was either small cell lung cancer or non-small cell lung cancer. And in the late 90s, we were still arguing whether we should be treating non-small cell lung cancer at all, whether we had any effective drugs at all. We certainly didn't care whether patients had smoked or not. It didn't help us with our biology, didn't help us with our drugs, didn't help us with anything. We certainly didn't have any technology to do any molecular analysis on any tumor samples or any cancers. And the survival of patients with lung cancer at that point was usually way less than 1 year. Things have moved on a lot since then. The ALK gene was actually identified to be causing cancer, many of you will know this perhaps, in 1994. And actually, it wasn't in lung cancer it was identified in at all, as a type of very rare type of cancer of the lymph nodes called ALCL. I can tell you what that is later. And there's a very rare type of ALK positive lymphoma called ALCL, and fine, we knew that, but we couldn't do anything with that information. Things started to really kick off in 2007 when a Japanese group were looking for new drugs, and they were looking for new drugs and identified in a group of cells from a Japanese patient who'd smoked a reasonable amount, actually, as it happened, that there was an abnormal gene in that cancer's cells that shouldn't have been there, and that was a very similar type of ALK fusion to that one had been identified back in 1997 in lymphoma. And that's Dr. Soda and his colleagues who published in the eminent journal of called Nature that ALK fusions were present in a small subset, about 3 to 5% of lung cancers, and they actually caused the cancer to grow. So, what does that mean? Well, at the time, Pfizer, the large conglomerate drug company, had a tablet that they were developing, and they knew it had some activity against ALK, but actually ALCL lymphoma was curable with chemo in many patients. So why do you need a tablet when you're curing people? There isn't a problem to solve. They actually designed this drug, which was called PF2341066 at the time, to switch off another abnormality that we see in a type of lung cancer and other types of cancer actually called MET, M-E-T. But they knew that it actually had some activity against the ALK protein. So when Dr. Soda and colleagues published this information to say that ALK positive lung cancer exists, there were already trials ongoing in the US where they're trying this drug to see whether it works or not. Now, that's all great, but how do you actually identify whether a patient's lung cancer is ALK positive or not? We take this for granted now, right? But back in 2007, we had no technology to do that. There was a group in the Massachusetts General Hospital and the path lab there run by a colleague of mine called John Rifati, who developed a test called ALK-FISH. And they worked it up, and they were able to rapidly screen patients' tumor samples as they were coming through, and they identified a few people whose tumors were ALK positive, and they were allocated this drug, PF2341066, and guess what? Their cancers miraculously shrank down. And Pfizer, to their benefit, totally changed their whole program for what to do with that tablet and said, forget about MET. There's no point in thinking about MET. We need to develop this to switch off ALK lung cancer. And that's exactly what happened. They were called phase 1 trials because they don't know what the right dose is. How frequently do they give the tablet? Do we give it every day? Do we give it twice a day? Do we give it 3 times a day? What's the right dose? Who do we give it to? Who do we don't give it to? And I remember being in the audience in a meeting in Chicago, in the American meeting in Chicago in 2010, where my colleague presented this first data, and the trial, the phase 1 trial, is called the Profile 10001 trial. And the audience were agog at the dramatic benefits that they were seeing, because we had never seen anything quite so dramatic in this disease, which at that point we didn't understand, because we didn't understand what the nature of this beast is, ALK positive lung cancer. So that was in 2020. Only a handful of years after the drug started to, 2010, only a handful of years after the drug started to get developed. Only 2 years after that, industry had already worked out next generation ALK inhibitors. And I was lucky enough to be elected by my peers to be reviewing this data at the European meeting in Vienna in 2012. And I was in a session about drug development, and the session was totally empty. There must have been about 5 people in the room. And then it was time for the ALK presentations, and we were going to be discussing 3 drugs. The first, and they're in sequence. First drug was LDK378. Next drug was AP26113, and the third drug started with CH and has got about 8 different numbers afterwards. And at that point, the whole room packed up. There must have been at least 10,000 in that room to listen to that data. And we finished discussing the data, and the hall just emptied because everybody was there to understand the ALK data. So what are these drugs? PF2341066 is called crizotinib. We use it day in, day out. LDK378 is a drug that most people don't use anymore, called ceritinib. AP26113, I'm sure there's a few people on it here in this room, brigatinib. CH ... with many, many different numbers. A Chugai drug developed initially in Japan by our Japanese colleagues. Very popular drug, alectinib. So we've been developing these drugs since 2010, 2012, when the first data in alectinib was identified. And since then, we've got multiple ALK inhibitors that have been developed. Lorlatinib is the one of the most modern ones, with groundbreaking data presented at the American meeting just last year, suggesting that this may be the drug that we might think about starting our patients with at the first time that we see them. But there are many others. There's a drug, for example, called ensartinib. In fact, there are so many drugs that the WHO, whose job it is to name drugs, says, well, you can't have the word nib anymore at the end of the drug because there are so many bleeding nibs. We haven't got enough letters in the dictionary. And there are so many ALK inhibitors, we're going to create a different suffix for the class of drugs called ALK inhibitors. And you'll now find them ending in the word alkib. So we have, for example, the next drug that's going to come along is called neladalkib. I'll talk about that in a minute. We've got 3 Chinese drugs already with data: iruplinalkib, envonalkib, and ficonalkib. I have to be very careful how I pronounce that. So I was reflecting on my ward round and what I was discussing with my patient. I was reflecting on what she said to me, actually, because one of the things I've learned over the years is you've got to listen to your patients. They tell you a lot. Strange but true. And I was reflecting on several great years of quality of life. So I thought, you know what, how do we make this better? How do we improve this? And I thought, actually, there's several ways we can do this. Can we pick up cancer earlier? Can we pick it up not when it's stage 4, but can we pick it up when it's stage 1? Well, let me tell you what, this is really, really hard to do. And I'll give you an example. We know that in lung cancer, the biggest risk factor that we have in general in lung cancers is tobacco exposure. And that is by far the biggest risk. And of course, that doesn't affect hardly anybody in this room. But the NHS in England is, I think, leading the world in lung cancer screening. And they are picking patients most likely to have lung cancer when they have a CT scan. And that's on the basis of tobacco exposure and a few other things. And if you do a CT scan on those high-risk patients and you test 100 patients with a CT scan, you will pick up 2 lung cancers. So how on earth are we going to find lung cancer in the average bloke that's just walking down the street, who is like you and I? It's going to be next to impossible if we're going to be relying on CT scans. So you'll say to me, well, look, I read the Daily Mail and I've heard there's a blood test that you can have. It costs a few quid. I've got a bit of cash in the bank. Why don't I go and have one of these fancy blood tests? It's called MCED test, multi-cancer evaluation detection test. Sure, you can pay for it. The NHS has actually been doing quite a lot of work to figure out whether it can pick up cancer early. And guess what? Yeah, in some people it can pick it up, but it doesn't necessarily pick it up early. It just picks it up at an advanced stage or locally advanced stage when the patient still doesn't know about it. So all you've done is you've brought forward the diagnosis in many patients by about 2 to 3 months. Some would argue you've ruined their 2 to 3 months of ignorant bliss rather than finding out what they need to know. So there's a lot that we still need to do to develop these fancy blood tests that we can pick up cancer very early. But undoubtedly, we are already picking up some patients with very early stage lung cancer, stage 1, stage 2. And we're noticing that these patients, some of them have ALK positive lung cancer. And we're giving them ALK inhibitors, and we're preventing relapse. We don't know yet, but I'm sure when we followed up this group of patients, we will find out that we are curing more patients as well. This is a whole different group of patients that we need to help and support, that we need to find, encourage and embrace and bring along to the group. We need to find out what needs these patients have, because I'm sure it's going to be very different to those that are in this room. So the other thing I was thinking about when we're thinking about quality of life is more better? I mean, it sounds great, doesn't it? You know, we throw more at the problem, we're going to get on top of it. What does that mean? In general, in medicine, more means more drugs. So if we add more drugs, do we get better outcomes? Well, I can tell you we definitely get more side effects. I can tell you that for sure. And boy, we've got enough side effects as it is, I think, frankly. So the question is, for the additional side effects that we're going to get, is the bang worth the buck? Is the quality of life worth the additional survival that we're going to get? This is something that we're really struggling with in another type of lung cancer called EGFR mutant lung cancer, where we know that if we add in other drugs, we can extend life, but boy, do we create more problems with side effects. Is it worth it? It's a question. Is more better? Should we be resecting, taking out the primary tumour? So many of my patients want to have their lung cancers taken out. So many of them want to have the whole lung taken out. They have both lungs taken out if they could. Is that really going to put us in a better place? For some, it definitely will. For some, it's a no-brainer. We should definitely be doing that. For others, definitely not. And then there's a grey area. How do we choose? I don't know. We need to evaluate this and many other things in more detail. The opposite question also holds. If we've asked, is more better, then the other question is less better? Can we get better outcomes by not hassling our patients as much as we do? Do I really need a brain MRI every 2 months, 3 months, 4 months? You're going to have this debated, right? So I'm interested to know what will happen. If you are taking lorlatinib as the first ALK inhibitor that you've ever had and you haven't got relapse after 2 years, the data suggests you will never get it. Should you still be having a 3-monthly MRI? I think you can make an argument no. If you have brain metastases with lorlatinib and your cancer has been under control for at least 16 months, the data suggests that it's unlikely to relapse. Do you still need a brain MRI? Let's find out what the experts argue tomorrow. I think they can make arguments both ways. If we've got these new drugs coming online, do we use them up front? Or do we save them for when we need to really use them? Are the brigatinibs and alectinibs that we're using now still going to be the drugs that we're using in the next few years? And if we're doing less, what about things like eating less? Do we eat less carbs? Do we go keto? Is that what we need to do? Well, there's data that suggests that keto is great for you, and there's data that suggests it promotes cancer as well. So how do we choose? I don't think we know. So having reflected on this, boy, it was a long ward round, let me tell you that. I thought, we need to personalize our care. That's what we need to do. Because actually, no two patients are alike. Each of you in this room have your own unique story. And you have your own unique trajectory. And everybody's outcome is going to be different. Now, I see this because I see a lot of outpatients, and I often liken a physician's job to being like the pub landlord, because you get to meet a lot of people and you hear a lot of stories, and there are no two people who have the same issues. Everybody's got a slightly different issue. What one person's prepared to tolerate is going to be very different to what the next person's going to be tolerating. My conversation with somebody very senior in their life is going to be very, very different to a youngster who's diagnosed, if we're taking it to its logical extremes. So if we're thinking about personalization of care, what does the future hold for ALK-positive lung cancer? Well, I would say we live in a time of transformative care. And I don't say that lightly because I'm a clinician scientist. We see this, we breathe it, we understand what the transformation of the care that we deliver is. How I treat my patients with ALK-positive lung cancer today is very different to how I treated my patients 12 months ago. And that was very different to how I'm treating my patients the 12 months prior. If I look at how I'm treating my lung cancers in general, compared to when I first started treating them in 1997, it's totally different. Should you be surprised? No, look at your mobile phone. Your mobile phone now is totally different to the one that you were first purchased or first were given. So we live in amazing times. We're in a time, an era where we can take a tissue biopsy, we can sequence the genome of the whole cancer. We can sequence it so efficiently, we don't really know what to do with the information, how to actually sift through the junk to find the pearls of wisdom. Such is the pace of technological advance. And I'm really proud of some of the things we're doing here in the UK. I mean, we knock the NHS a lot, quite rightly, I think, in some reasons. But actually, there are phenomenal things that we have achieved here in Europe, in England, that Europe and the US is actually looking at and saying, wow, I don't know how these guys are doing it. Lung cancer screening being one of them, and the availability of something called liquid biopsies, which the NHS has adopted as fully funded for a patient at the beginning of their cancer journey. We're the only country in the world that is providing that routinely covered. And we've got fantastic new drugs coming along. Last year, we had a discussion about a drug called NVL-655. It's got a drug, it's got a name now. It's not called NIB, it's called Alkib. It's called Neladalkib. It's going to be a great drug. In fact, it looks so active, it's now even in what we call randomized phase 3 trials, where it's being compared against one of the standards of care called alectinib. And this trial is going to be run in the UK for new patients. It's called the ALK trial. But importantly, science continues to move and evolve, and we've got an entirely new class of drugs coming through. In fact, we've got two new classes of drugs coming through. We've got the class of drugs called antibody drug conjugates, a totally new class of drugs, very similar to chemo in some respects, but they seem to have some activity in ALK positive lung cancer. And we've got a whole new class of drugs called PROTACs, or molecular glues. These are very novel drugs. I don't think we've got a single PROTAC licensed for solid tumours as yet. And there is at least one that I'm aware of, which is going to be developed specifically for ALK positive lung cancer, which will be coming, I hope, to the UK sooner rather than later. So look, I'm going to close, and I'm going to close by celebrating. And I'm going to close by celebrating something that's really important to all of us in this room, and that is the word hope. Hope is what drives the researchers in the labs. That's what drives them working at night when they're trawling through their data, trying to get everything in on time. Hope is what drives the clinicians that are seeing the patients day in, day out, trying their best for the people that we see. And hope is what's empowering all of you and changing you from patients to what I call advocates, because you are advocates. You are advocating for your particular disease. But hope is alive and kicking, and I can feel it in this room with the strength of the people in this room. And hope is a celebration. It's bringing the medicines from concept through science, through progress and research to real life, through new strategies to buy us time and to give us new life. So look, I think we should raise a glass if we can. I've remembered mine. To ALK Positive UK. To everything that ALK Positive UK has achieved, to what lies ahead. The future's definitely bright. The science is tremendously strong. And together we can make it unstoppable. ALK Positive UK. Cheers. Thank you.
I would just like to thank Professor Popat for his very encouraging words. So I wasn't aware of some of the advancements that are on our horizon, which is really, really encouraging and hopeful for all of us. So that's great. So thank you very much indeed. Professor Popat comes to every one of our conferences, and I really find his words inspiring, and I can see people nodding around the room, so I'm not the only one, which is good, news. And yeah, he's a great supporter of the organisation. So, you know, I personally would like to say thank you, and on behalf of our trustees as well, to say thank you very much indeed, Professor Popat. So, and the last word is just to say, I hope you have a really enjoyable rest of the evening. I know for some of you it will be like, oh my gosh, that's my bedtime. So, yes. So if I don't see you this evening, then have a good night's sleep. And I look forward to seeing you all in here tomorrow for, some robust discussions and a lively debate, I suspect. And lots of good conversations amongst ourselves. So, and if everyone's feeling a little bit still unsure, then I'll stay here for a good hour or so more. Maybe I kind of need my bed as well. But then come and see me, and I can just go through anything what's going to happen over the weekend. But it's great to see you all here. You should stand where I'm standing. It's amazing. There's so many people in the room. It's fantastic. So I will get round all of you, I promise, she says. But I will. So thank you very much indeed for making the effort to come. I'm confident you will get lots out of this weekend. And I look forward to catching up with you so that you can share what you've learned or just gained from being here. So that's all I'm going to say now. I'm going to get off the stage. Just say thank you very much. Have a good rest of the evening and a good night's sleep. Thank you, everyone.